Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners, and welcome back to another episode. Today, we have no guest, no panel, although if I ever do a panel, who would you want on it? Drop them in the comments. But it's just me and you today talking all things airway and how to keep our lungs calm when the OR is anything but calm. So today, we're zooming in on pharmacology of airway control, how the drugs we use actually change airway tone, inflammation, and gas exchange. A lot of you tell me, I get ventilation mechanics, but I don't totally get how the bronchodilators and steroids can fit into my anesthetic plan. So that's our roadmap for this episode, how beta agonists, anticholinergics, and steroids actually make airways behave at the receptor level. What to watch for in reactive airway patients under anesthesia, when and why we might reach for inhaled nitric oxide, and how to optimize respiratory drug delivery perioperatively, and then we'll integrate it all with a case vignette like I do. We integrate it into actual clinical scenarios because that's what this is all about, applying things clinically, taking care of patients safely. So you can see how this shows up in a real-life anesthetic plan. By the end of this podcast, I want you to be able to look at a wheezy pre-op patient and think, okay, I know what's happening at the receptor level, and I can build a plan instead of just memorizing a mechanism of action and dose. All right, let's breathe in, let's breathe out, and let's get into it. The first segment we're going to talk about is beta agonists, opening that bronchodilator door. So let's get started. The beta-2 agonists, things like albuterol and terbutaline, and in more severe scenarios, even epinephrine. I want you to see these not just as puff, puff, the patient gets better, but as a little signaling cascade. Again, it's all about mechanism of action and understanding what is going on. So what is actually happening here? When a beta-2 agonist hits those beta-2 receptors on airway smooth muscle, here is the pathway that it goes through. So let's go through this pathway. So it starts with those beta-2 receptors being stimulated, which in turn stimulates our G's protein. A G's protein, remember, is that type of G protein that acts as the molecular middleman between a receptor on the cell surface and the enzymes within the cell, inside the cell. When a beta-2 agonist binds to that receptor, it taps the shoulder of the G's protein and says, wake up, we need bronchodilation. So how does that occur after that? Those G's proteins are stimulated, which increases adenylyl cyclase. Those G's protein that activates adenylyl cyclase, it's basically this enzyme whose whole job is to make more cyclic AMP. Think of the G's proteins turning the on switch for cyclic AMP through increasing adenylyl cyclase. So adenylyl cyclase then starts pumping out cyclic AMP. You have that increase in cyclic AMP, the messenger that tells smooth muscles to relax. That cyclic AMP activates protein kinase A, PKA. Basically, a high cyclic AMP flips on protein kinase A, your smooth muscle relaxation supervisor. So this PKA decreases intracellular calcium availability. It inhibits light chain kinase, LCK, and the result of that is smooth muscle relaxation, aka bronchodilation. So my favorite analogy for this is thinking of cyclic AMP as the bouncer at a club, which I talk about like club talk a lot, which for someone who hasn't been to a club very much, it's kind of interesting to keep using this analogy. But think of cyclic AMP as a bouncer at a club who kicks calcium out of the smooth muscle party. Less calcium means less ability to contract, so the smooth muscle within the airway chills out. So some clinical pearls for beta-2 agonists. Selective versus non-selective. We obviously love beta-2 selective agents for our respiratory control, like albuterol, because they mainly target the lungs. More non-selective or beta-1 spillover, you have more tachycardia, arrhythmia risk, and tremors. So in terms of perioperative timing, for a known asthmatic or reactive airway patient, I love a pre-induction albuterol nebulizer. It's like giving those bronchioles a pep talk before you touch the airway, before you start to stimulate the airway. A volatile induction. So remember that desflurane, especially at high concentrations or during light anesthesia, can be airway irritating and trigger bronchospasm. So having a beta-2 agonist on board reduces that risk. And desflurane being the fastest of our anesthetic agents in terms of its properties, blood gas solubility. You guys are all nodding along because you know all of those things from my prior podcast, right? Right. And in our bariatric patients, it's a great option for the facilities that are still using desflurane. You can give them a preoperative albuterol nebulizer to mitigate any of that airway irritability that comes along with desflurane. In terms of intraoperative rescue, so if you hear wheezing, if you have increased peak pressures, you have that shark fin end tidal CO2 waveform. These are all things that lead us to believe that there is a bronchospasm going on. One of the first pharmacologic moves is inhaled albuterol via the circuit, plus deepening your anesthetic and treating the triggers, of course. But in terms of pharmacology, our inhaled albuterol is our mainstay go-to for intraoperative bronchospasm, unless it's very severe, which we go towards epi, but we'll talk about that in a little bit. So mentally tag beta-2 agonists as increased cyclic AMP and relaxing those airway smooth muscles. Another huge player, especially in COPD, is our inhaled anticholinergics, things like ipratropium and tiotropium. Those are our inhaled, most commonly used inhaled anticholinergics. So COPD patients often have obstruction that is vaguely mediated. So translation, the parasympathetic system is squeezing their airways. The vagal reflex, bronchoconstriction. What is actually happening here? Here's the typical reflex. You have an irritant, secretions, or inflammation that stimulates the vagal afferents. And the vagus nerve then sends acetylcholine to our M3 muscarinic receptors on our airway smooth muscle. Those M3 receptors have GQ protein and stimulate those GQ proteins. The GQ proteins then increase phospholipase C, which increases IP3, and you have a release of calcium from the sarcoplasmic reticulum. This increase in calcium causes contraction, which causes bronchoconstriction. If you have contraction of that smooth muscle, you're going to have bronchoconstriction. So basically, beta-2 agonists relax from one angle where the vagus nerve tries to tighten things from another. This is how anticholinergics, like our ipratropium and tiotropium, are competitive antagonists at the muscarinic receptors, especially M3. So they block acetylcholine from binding to M3. That means you have a decrease in IP3, a decrease in calcium release, and a decrease in smooth muscle contraction. Result, bronchodilation, especially in our COPD patients where that cholinergic tone is a really big deal. So I like to talk about the parasympathetic and sympathetic nervous system as a pendulum because that's how Dr. Sasha Elijah taught me the autonomic nervous system. So in these COPD patients, I want you to think of that pendulum has swung towards that parasympathetic nervous system. And how do we get it back to being more of that sympathetic nervous system? Bronchodilation that we see with the stimulation of the sympathetic nervous system, rather. The way that we do that for these COPD patients who have that parasympathetic predominance in the smooth muscle of the lungs, we need to get it back to the sympathetic, a little bit more of that sympathetic tone, which is where our inhaled anticholinergics come in, right? Right. So the clinical application for this is that a great combination therapy for our COPD patients is a beta-2 agonist plus an anticholinergic, especially in those COPD, like I said, or peribronchospasmic patients. You're tackling airway tone from two different sides, two different mechanisms of those airway structures being contracted and putting interventions in that bronchodilate. Side effects, however, of our inhaled anticholinergics are similar to the ones that you've known and not memorized, but know from giving IV anticholinergics. So side effects would be dry mouth, which in the OR can be kind of nice for secretions, but remember, very dry secretions can become thick and tenacious and have a whole other set of issues, like mucus plugs and all of those things, especially in our chronic COPD patients. Hydration and humidification still matter. Anticholinergics are your block the squeeze drugs. They don't boost relaxation, but they prevent constriction. That is the summary of our anticholinergic inhaled anticholinergics for bronchodilation purposes. So segment 3, we're going to talk about corticosteroids. It's one of those words I say weird. I know I say it weird. I'm very sorry. Calming that chronic inflammation. So far, we've talked about opening the airway, but in asthma and many reactive airway diseases, it's not just a tight tube problem. There can be chronic inflammation that's underneath. That's where our glucocorticoids live. They don't work in seconds like albuterol. They change the baseline reactivity of the airway over hours to days. So let's talk about, again, mechanism of action, which is super important to understand. Steroid 101 for our airways. Steroids like methylprednisolone, hydrocortisone, and our fluticasone are lipid soluble. They diffuse into the cell. They bind to the intracellular glucocorticoid receptor, okay? This complex moves into the nucleus and alters gene transcription, decreases pro-inflammatory cytokines, IL-4, IL-5, IL-13, etc. You have a decrease in eosinophil survival and activation. You have a decrease in expression of inflammatory mediators and adhesion molecules. So the net effect of all of these things is you have decreased airway edema, decreased mucus production, and decreased airway hyperresponsiveness. Clinical translation for us, time course. This is not a rescue drug. Think of this in hours to days, not minutes, right? So for perioperative strategies, if you have a patient that comes in for surgery with a known active severe asthma or reactive airway disease, pre-op optimization often includes stepping up inhaled or systemic steroids. It is an option for those patients. After a bad intraoperative bronchospasm, a dose of IV steroid is common to prevent the second wave of inflammation. That methylprednisolone is great for that. Let's talk about stress dose steroids. I talked about that on a podcast with Dr. Becky Ashlock about our endocrine system and talking about stress dose steroids. But if your patient is on chronic systemic steroids, we have to think about our HPA axis suppression and whether or not they're going to need a stress dose for surgery. That's a whole endocrine rabbit hole, and we have a whole podcast on that. So go listen to it to hear all about that. The pearl is systemic versus inhaled. Okay, so we're going to talk about steroids in terms of systemic steroids versus our inhaled. So our inhaled steroid, like fluticasone, has more local airway effect, less systemic impact, okay? That is key for our inhaled steroids. So if you're thinking about why we would give an inhaled versus IV, for example, for our test, quiz, boards, whatever, it has a more local impact, less systemic effects and less overall side effects. If you're trying to treat that area, giving it inhaled just hits those receptors where we want the impact to occur or the chain reaction, and that's why we're giving it. For IV steroids, so our methylprednisolone, our hydrocortisone, systemic or anti-inflammatory, and stress coverage. So in your brain, bronchodilators open the tube or the airways. Steroids remodel how irritable the tube is or the airway is long term. All right, let's talk about how we would use these things actually in the operating room. When you see an asthma or COPD patient or a reactive airway in pre-op, what should immediately start firing in your brain, rather? All right, things that irritate airways. We want to start thinking about our plan and ways to avoid any type of airway irritability. So, desflurane, we talked about this already, especially in high concentrations during light anesthesia. Instrumenting the airway, direct laryngoscopy, or laryngoscopy in general, ET tube versus LMA, and suctioning. Secretions, blood, gastric contents, we're thinking about all of these things in terms of ways that are going to stimulate our airways that we want to try and avoid. We always try to avoid all of these things in the airway for the most part, but even more heightened for these types of patients. We also consider histamine-releasing drugs to avoid. So we know you guys are nodding along which medications release histamine, because anytime you think of histamine, you think of bronchoconstriction and issues at the airway. So those are our morphine, codeine, atracurium, and mivacurium. Those are our histamine-releasing drugs. We think about light planes of anesthesia during stimulation and try to avoid that at all costs. Things that can actually help with airway irritability. So now we've talked about the things that we're going to avoid, and now let's talk about things that actually help with our airway irritability. So our volatile agents actually have a bronchodilatory property. Our sevoflurane is the best bronchodilator that we have. Isoflurane also bronchodilates. Desflurane, as we've said, is an airway irritant. Ketamine is an NMDA antagonist, you guys know this, has direct bronchodilatory properties and sympathomimetic support. So this is a great option when you're worried about hypotension and bronchospasm simultaneously. We always avoid histamine releases, so choosing fentanyl or hydromorphone or remifentanil over histamine-heavy agents. We don't give a ton of morphine where I'm from and the facilities that I work at. So if you are at a facility that uses morphine, definitely avoiding any type of histamine-releasing agents like morphine. Using cisatracurium, rocuronium, vecuronium instead of atracurium if possible. We already talked about avoiding atracurium. So a quick pathophysiology tie-in is airway tone is a three-way tug of war. We have the sympathetic system, that Beta-2 stimulation causes relaxation. We have the parasympathetic, vagal and M3, which causes constriction. And then we have inflammation, which makes the airways hyperreactive to both mechanical and chemical stimuli. So basically your anesthetic is deciding which side of the rope do you want to pull harder on. Giving beta-2 agonists and volatile bronchodilators would result in more relaxation, right? Blocking acetylcholine would remove some of the vagal squeeze, and treating inflammation with steroids makes everything less irritable over time. So again, that pendulum, it's almost like the pendulum in this case has like three. It's like one of those like never-ending pendulums, but it goes three ways. Those are the three types of stimulation in our airways that we have, and you have to consider each of them when creating an anesthetic plan for a patient with airway irritability. So our next segment is we're going to talk about inhaled nitric oxide, the selective smooth operator, as it is called. At least I'm calling it that today. Okay, so now for the cool kid of the pulmonary drug world, inhaled nitric oxide. Not to be confused with nitrous oxide, two very different things, or INO is the abbreviation for it. This one's less about bronchospasm and more about the pulmonary vasculature, your pulmonary artery pressures, right ventricular afterload, and our VQ matching. That's what I want you to think of when you think of nitric oxide. Again, I'm going to repeat that because it's really important. So when you think of inhaled nitric oxide for patients, we are talking about pulmonary artery pressures, right ventricular afterload, and VQ matching. Let's break down the mechanism of nitric oxide at the molecular level. When we deliver nitric oxide gas into the lungs, it diffuses into nearby pulmonary vascular smooth muscle. When it does that, it activates soluble guanyl cyclase that increases cyclic GMP. The cyclic GMP decreases intracellular calcium, and we have smooth muscle relaxation. The best part is that it only reaches vessels in the ventilated alveoli. So you get selective vasodilation in ventilated areas, improving our VQ matching. So systemic blood pressure is usually spared because the nitric oxide is inactivated quickly by hemoglobin. So it doesn't meaningfully dilate systemic vessels. So clinical indications you'll see: neonatal pulmonary hypertension, post-cardiac surgery with high pulmonary artery pressures and right ventricular strain. So again, all of my CT ICU nurses are nodding along because they've probably had the most experience in giving nitric oxide on the unit. Sometimes we give it in severe ARDS or refractory hypoxemia as a bridge with rebound pulmonary hypertension. If you abruptly stop inhaled nitric oxide, those pulmonary vessels can suddenly lose that vasodilatory support. The pulmonary pressures can shoot back up or go even higher. The right ventricle, which was just starting to relax, now gets slammed again. And this is what we call rebound pulmonary hypertension. So what does this mean? We have to wean inhaled nitric oxide gradually, not just flip the switch off and hope for the best. We have to have a plan for weaning as well. So that is the breakdown of nitric oxide, inhaled nitric oxide. I will be showing my class and my cohort pictures of how we do this in the operating room. It takes a team to set it up and be able to deliver it intraoperatively for patients who need it, who are critically ill in the OR. Heading into our next segment, optimizing respiratory drug regimens perioperatively. So let's talk logistics. You can know all about this receptor pharmacology in the world, but if you don't have if you don't time and deliver the drugs correctly, you won't get the effect that you want. You have to have that plan. We always have plan A, B, C, D, E, F, G in anesthesia. And here we go. Let's talk about our pre-op checklist for reactive airway and pulmonary patients. So ask yourself, ask yourself and the patient, have they taken their home inhalers and steroids today? In general, we want them to continue their routine respiratory meds unless there's some very specific reason not to. Do they need, another question you ask yourself, do they need a pre-induction boost? For someone with a recent wheeze, cough, cold last week type of patient, consider that pre-op albuterol nebulizer in the pre-op holding area. The next thing you ask yourself is, what airway device will irritate them the least? An LMA, the laryngeal mask airway, is generally less stimulating than an ET tube. So if appropriate, obviously, for the surgery and for the patient, that is something we consider. In terms of our post-op plan, thinking about humidified oxygen, especially in our mouth breathers, would be a great option. Having bronchodilator access in the PACU, giving that in report to the PACU nurses that this patient may or may not have had an issue intraoperatively, and we may need bronchodilators in PACU. We at least want to make sure that we have access to that. Providing a multimodal analgesia to minimize high-dose opioids and respiratory depression is key. We love a multimodal anesthetic, right, these days in 2025. So that's a great option for this patient. Another thing that we have to consider or think about in our anesthetic plan and management of these patients is why drug delivery method matters under anesthesia. So under anesthesia, aerosol behavior changes. So particle size determines where it deposits. So you have our larger particles, which would be the oral pharynx and the upper airway, whereas smaller particles, inhaled agents, smaller particles get to the lower airway and the alveoli. So we're thinking about how we're actually delivering these medications intraoperatively. Humidity and circuit geometry matter. So filters, HMEs, long circuits can trap the particles that we're administering. Sometimes a T-piece adapter near the ET tube or a Y-piece improves deposition, okay? Our vent settings are important. Very low tidal volumes or long inspiratory pauses can change where the drug lands. So we have to work with our ventilators, our equipment, make sure our albuterol gets where we want it to be. Basically reaching the bronchi and not just our HME filters. So we incorporate that into the things we think about preoperatively. All right, segment 7, putting it all together. We're going to do what we love to do is tying it into this anesthetic plan, patient by patient, case by case. So the first case is you're taking care of a 45-year-old asthmatic for an elective laparoscopic cholecystectomy. The history is they've had asthma since childhood, uses their albuterol inhaler PRN, and inhaled steroid or long-acting beta agonist. So the combination drug rather. Recent URI within the last 2 weeks and still has a mild cough but no fever. Lungs mostly clear with a little end expiratory wheeze, okay? Our vital signs are stable, saturation's 98% on room air. Let's walk through our plan, okay? So preoperatively, we want to make sure that they took their usual inhalers this morning. We may consider giving a nebulized albuterol in pre-op as that bronchodilator warm-up for surgery and intubation airway manipulation. We also may consider a small IV steroid dose if they're very reactive or have had a recent exacerbation, depending on their baseline regimen and the institutional practice where I'm providing this anesthetic. So in terms of induction agents, let's talk about our induction agents. Propofol or ketamine? Propofol, the pros and cons, because everything in anesthesia is a pro or con and a risk-benefit analysis. The pro is its great suppression of airway reflexes. Propofol helps with smooth intubation. The cons can drop our blood pressure, but that's usually manageable. Ketamine, the pros is it has that bronchodilation and maintains blood pressure, even kind of increases heart rate and blood pressure rate. It's a sympathomimetic. The cons, you have more secretions and possible emergence phenomenon. For this moderate elective asthmatic with okay hemodynamics, many of us would choose propofol with good opioid blunting and maybe having ketamine in our back pocket if they decompensate or if we're really worried about bronchospasm. In terms of our airway choice, LMA versus ET tube. For a lap chole, we need controlled ventilation, protection from insufflation and aspiration risk, so typically we're going to use an ET tube. I would say we would use an ET tube. This patient needs to be paralyzed. People practice differently everywhere, but the safest option for this patient would be an endotracheal tube. So that's fine. We just know that it's going to be more stimulating than an LMA. So we want to make sure that the patient is deep enough at intubation. Consider lidocaine, bolus, pre-induction, or a topicalization of lidocaine if appropriate. You can do an LTA before you intubate, and that may be appropriate as well. Have albuterol ready on the circuit, ready to go. Our maintenance, use sevoflurane as your volatile because it has that nice bronchodilatory property, avoiding high-dose desflurane, especially in those lighter planes of anesthesia. Watch peak pressures and end-tidal CO2 shape. If you see bronchospasmic patterns, you want to think about deepening the anesthetic and looking at the hemodynamics with that. Giving an inhaled albuterol. Consider a dose of IV steroid. Ensure that there's no mechanical issue first. Obviously, we're going through our differential diagnosis before we just start giving all these things and treating, so we make sure there's no kinked tube, we're not main stemmed, we don't have secretions and a mucus plug, doing our differential before we start treating a bronchospasm, but doing all these things quickly. In terms of emergency PACU, making sure they are fully reversed from their neuromuscular blockade and able to move air before extubation, right? We're making sure they're hitting all those extubation criteria. Extubate either very deep, no coughing or bucking, and deep extubations are very controversial and provider dependent. But you can consider that, or fully awake with good reflexes. Avoid the in-between where they're half coughing on the tube, right? We just want to minimize the most airway stimulation while keeping the patient safe. Having albuterol available in PACU and a low threshold for giving treatment if wheezes or increased work of breathing appear. That's what it looks like to translate receptor pharmacology into actual anesthetic mindset, right? So that is our one clinical scenario. I mentioned that I was going to go over epi, and then I didn't go over epi. So we're going to do it now. Let's talk about how epinephrine makes a difference on our airway as well. So in worst case scenario, if our albuterol isn't working, the patient's not improving, I always have epinephrine in my back shelf medications to give in this type of crisis. We give it never a good day when we're having to give epi in the operating room. However, we need to know how to do it, what to do, and why we do it is really important. So let's break it down on how epinephrine breaks severe bronchospasm at the molecular level. So when a patient is in severe bronchospasm, airway smooth muscle is clamped down, mucus is plugging, and ventilation is failing. Epinephrine works because it hits multiple receptors simultaneously and fast. So let's break it down receptor by receptor, pathway by pathway, okay? So first is our beta-2 receptor activation, is the main bronchodilator mechanism. So this is the primary way epi opens the airway. So let's go through it step by step in the intracellular sequence. So epinephrine binds beta-2 receptors on airway smooth muscle. Beta-2 receptor then activates its coupled G's protein. That G's protein, again, stimulates adenyl cyclase. We know this. We went over this pathway. Let's continue. Adenyl cyclase increases cyclic AMP production. Cyclic AMP activates our protein kinase A, our PKA. And the PKA phosphorylates proteins that lower intracellular calcium, inhibit that myosin light chain kinase, relax actin-myosin cross bridges. And our outcome is smooth muscle relaxation, immediate bronchodilation. This is why our beta-2 agonists like albuterol use the same pathway. Epi just hits it harder and faster. The second pathway or receptor, we're going to go through both, that epinephrine works on is our alpha-1 receptors. We know this about epi. It decreases mucosal edema. So in severe bronchospasm, it often includes airway swelling, especially in anaphylaxis, right? Epinephrine activates alpha-1 receptors on airway mucosal blood vessels. You have alpha-1 that is stimulated. Those GQ proteins are activated, which then activates our PLCs. The PLCs increase IP3 and DAG. All of these acronyms I'll have broken down in the description of this podcast, okay? IP3 increases intracellular calcium in vascular smooth muscle and vasoconstriction of mucosal vessels. The outcome is it shrinks airway swelling, physically increasing the lumen size. This is why epi is life-saving in anaphylaxis, this bronchodilation plus reduced airway edema. It's a twofer, two birds, one stone, the one stone being epi. The two birds being airway edema and bronchoconstriction. All right, the third pathway and receptor that epi works on is beta-1 and beta-2 effects. Basically, you have improved gas exchange and ventilation. So epinephrine increases heart rate with beta-1 and cardiac output with beta-1. It also helps with diaphragmatic perfusion with beta-2. This helps oxygen delivery while the airway is opening. We also know that beta-1 and the heart rate increases for our patients with sick hearts is not ideal, so keeping that in mind. And again, doing that risk-benefit analysis. Is this severe enough to give epi and potentially increase myocardial oxygen demand and decrease myocardial oxygen supply? Can my patient tolerate that? Can their heart tolerate that? And considering that when reaching for epi in the OR. The next thing that epi does is it has mast cell stabilization, stops the trigger. So epi also inhibits mast cell degranulation, especially important in, again, anaphylaxis. So the mechanism that it does this is it has that beta-2 activation and increase in cyclic AMP within mast cells. This high cyclic AMP then prevents release of histamine, leukotrienes, and prostaglandins. And the outcome of that is it stops inflammatory storm that fuels the bronchospasm. And that is why and how we give epi with anaphylaxis and why it's the go-to med for it. The fifth and final receptor and pathway that it works on is improved mucociliary clearance with beta-2 activation. So beta-2 activation also increases ciliary beat frequency. It thins mucus, helps mobilize secretions. The outcome, airway patency improves faster. So putting it all together, epi works because it hits every part of bronchospasm. The mechanism receptor result, bronchodilation. We have our beta-2 increasing cyclic AMP and airway smooth muscle relaxation, reducing mucosal edema with alpha-1 vasoconstriction of airway mucosa. It improves cardiac output with beta-1, better oxygen delivery. It stops allergic mediator release with beta-2 within mast cells. So we have less histamine, leukotrienes, cytokines. It improves mucus clearance by beta-2 with less obstruction. So why epi works when albuterol fails? Albuterol is only beta-2. Epi is beta-2 for bronchodilation, alpha-1 for edema reduction, beta-1 for hemodynamic support, and beta-2 for mast cell stabilization. So epi treats every component of life-threatening bronchospasm. That is how epi works in terms of our lung physiology and why we would give it, especially in bronchospasm that has to do with anaphylaxis. However, giving epi in a severe bronchospasm that is not anaphylaxis necessarily is appropriate in those certain patient scenarios. All right, let's do a super fast recap so you can quiz yourself on your drive or on the treadmill, wherever you're at listening to this, okay? So beta agonists. Beta-2 stimulation causes those G's proteins to be stimulated, increasing what? I know you said cyclic AMP. Great job. Which stimulates our pKa, decreasing what ion? Calcium, which results in smooth muscle relaxation. Think increased cyclic AMP, we are relaxing that airway. Let's talk about our anticholinergics and think about that in terms of quick review. We are blocking acetylcholine at what receptors with our inhaled anticholinergics? M3. I know you said it. When we do this, we decrease that IP3 and calcium pathway, preventing constriction. We are blocking the squeeze. In terms of the pendulum being too far on the parasympathetic side, and we need our inhaled anticholinergics to swing the pendulum more towards the sympathetic side. All right, review our steroids. The steroids actually change gene transcription, decreasing inflammatory mediators and decreasing eosinophils. This reduces airway reactivity over what? Minutes? No? Minutes? Nope. Hours and days. So think about these as calming the baseline fire. Reviewing our nitric oxide that we discussed, nitric oxide stimulates guanyl cyclase, which increases cyclic GMP, which causes pulmonary vasodilation in ventilated alveoli, which improves our VQ matching and reduces pulmonary pressures with minimal systemic hypotension. So weaning slowly to avoid rebound pulmonary hypertension is really important in these cases. When you understand how these drugs work at these receptor levels, you stop memorizing, give this number of puffs, X, Y, and Z, and you start actually building your anesthetic plan. So what is tight? Why is it tight? Which side of this tug of war do I need to pull on? So I'll leave you with a little bit of encouragement because that's how we end these podcasts. And I hope you've learned something today as I've babbled on about the respiratory physiology and pharmacology. I always end with a bit of advice for learners. And here's my advice for you today. Don't shy away from things that you aren't good at. Okay, if you suck at epidurals, hey, you need to do more epidurals. If you're not great at art lines, do more art lines. If you are one of those providers and students who is not good at something and too embarrassed to continue to do them, I would really encourage you to reflect on that, to gain confidence in knowing that you can't be good at things that you never do, and doing them more often is going to improve your skill. Again, it's just a skill. What is most important for patient safety is understanding the physiology, pharmacology, and understanding why you're doing what you're doing for patients, and not whether or not you got the arterial line. Okay, we could do reps with anyone and they could learn how to place an arterial line, but it's the thought process and the critical thinking that is vital for patient safety. Okay. I hope you guys learned something today. I'll see you next time for the My Favorite Learners podcast. And as always, keep asking questions, put them in the comments, like, subscribe, follow, do all the things. We'll see you next time. Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.